We'll be breaking down all major concepts covered on the exam. But first, a quick disclaimer. This deep dive is strictly for medical education purposes, not medical advice. Any, clinical decisions should always involve a qualified healthcare provider. I'm Harvey.
And I'm Donna. We are expert MCCQE reviewers, and our mission is basically to help you, the Canadian medical student, feel a lot more comfortable with the exam review process.
Yeah, absolutely. So today's focus is the male reproductive system, specifically within the SO5 renal medicine section. And just so you know, our teaching material today is sourced entirely from reliable StatPearls articles.
Right. We want to make sure you're getting the best info. We're going to equip you with high-yield definitions, presentations, diagnoses, and management strategies for 4 really critical areas.
We're talking testicular torsion, penile fracture, priapism, and semen analysis.
Exactly. And when you look at the pathophysiology of urologic emergencies, there is this golden rule that dictates literally everything we do. Time is tissue.
Time is tissue.
You are working against a ticking clock. And absolutely no pathology exemplifies this race against time better than testicular torsion.
Right, so let's start with that ultimate time crunch. Testicular torsion is, well, it's exactly what it sounds like, a twisting of the blood supply and the spermatic cord.
Yeah, but what the exam really wants you to know is the why. It usually comes down to this congenital abnormality called the bell clapper deformity.
Okay, right. Let's visualize the normal anatomy first. Usually the tunica vaginalis is solidly adhered to the posterolateral aspect of the testicle, right? It holds it firmly in place.
Exactly. But in a bell clapper deformity, that attachment is way too high. So the spermatic cord just isn't tethered properly.
It's essentially free to twist inside the tunica vaginalis, like a clapper swinging freely inside a bell.
Right, hence the name. And this is known as intravaginal torsion. It's the most common mechanism for patients under 25 years old.
But we also have to be ready for the neonatal presentation, don't we? Because that's extravaginal torsion.
Yes, that is a vital pathophysiological distinction for the exam. In neonates, the tunica vaginalis hasn't actually adhered to the gubernaculum yet.
Oh, I see. So the entire sac, like the tunica vaginalis and the spermatic cord, they just twist together as one big unit.
Exactly. But regardless of the mechanism, the presentation is super classic. You're looking for an abrupt onset of unilateral scrotal pain.
And usually nausea and vomiting, right?
Yeah, frequently. And on physical exam, the testicle is often in an abnormal transverse lie, so it's sitting higher up in the scrotum than usual because the cord has literally been shortened by the twisting.
Now, I remember being taught to look for the Prion sign, where elevating the testicle relieves the pain in epididymitis, but not in torsion, and checking the cremasteric reflex.
Right, and that is exactly where the MCCQE will try to trap you. The StatPearls sources are explicitly clear here. Those signs are notoriously unreliable.
Wait, really? We shouldn't use the cremasteric reflex.
You cannot hang your diagnostic hat on a missing cremasteric reflex, especially in patients under 1 year old. The exam wants you to lean on the twist scoring system instead.
Okay, the twist score. Let's break that down.
It's a validated tool to determine the probability of torsion. It goes like this. A hard testes gets 2 points. Swelling gets 2 points. Nausea or vomiting gets 1 point. Absent cremasteric reflex gets 1 point. And a high-riding testes gets 1 point.
Let's actually think about why the testicle gets hard and swollen before it dies. I always like to picture a pressurized garden hose.
Oh, that's a perfect analogy.
Yeah, because if you start twisting that hose, you don't instantly cut off all the water, right? The thin-walled venous return gets choked off first.
Right, the veins collapse easily.
Exactly. The thick-walled arterial flow keeps pumping blood in, but nothing can get out. That causes severe venous congestion, swelling, and erythema.
It's only as the pressure builds and the twist tightens even further that the arterial flow is finally choked off, which leads to true ischemia.
Right. And that arterial cutoff is what we're looking for on imaging. Color flow Doppler ultrasound is the gold standard, about 93% sensitive.
But I'm going to push back on that for a second.
Yeah.
Let's say you're in the ER. The patient has a twist score of 5 or 6. They have a hard, swollen, high-riding testicle with severe nausea.
Okay.
You're probably thinking, let's just get the Doppler ultrasound to be absolutely sure. Do we actually wait for that ultrasound?
Oh, I see where you're going. That is a classic trap. If the twist score is high and clinical suspicion is strong, you send that patient straight to the operating room.
Straight to the OR. Do not order the ultrasound.
Delaying for imaging when the diagnosis is clinically obvious will literally cost the patient their testicle. You have a strict 6-hour window from the onset of pain for optimal testicular salvage.
And after that 6 hours, the salvage rate just plummets.
6 hours is terrifyingly fast. What if you're in a rural setting without immediate surgical access?
Then you have to attempt manual detorsion. The sources describe the open book method. You grab the testicle and rotate it from medial to lateral about 180 degrees, literally like you are opening a book.
Okay, and if you're successful, or they make it to the OR, the definitive treatment isn't just untwisting it and closing up. The surgeon must perform a bilateral orchiopexy.
Right, they tack down both testicles to the scrotal wall. Why both? Because that bell clapper deformity is bilateral in roughly 40% of cases. You must secure the contralateral side to prevent this from happening again.
So torsion shows us what happens when the blood supply is choked off from the outside. But what happens when that same high-pressure vascular system blows out from the inside?
Right. That brings us to our second urologic emergency, penile fracture.
Just like torsion, this is an acute crisis with a closing window, usually 6 to 8 hours. That threatens long-term function if missed.
And it's important to clarify, when we say penile fracture, we aren't talking about a broken bone. We're talking about the rupture of the tunica albuginea.
Right, which is this incredibly strong, inflexible fascial layer surrounding the corpora cavernosa. During a flaccid state, it's about 2 millimeters thick. But during an erection, it stretches and thins out to just 0.25 millimeters.
And it's wrapping blood that is under immense pressure. A fully rigid erection has an intracavernosal pressure of about 100 millimeters of mercury.
But the tunica albuginea is so unbelievably strong, it can withstand a bursting pressure of up to 1,500 millimeters of mercury.
Right. To rupture a structure that strong, you need sudden, severe, blunt trauma to the erect penis.
Like overfilling a car tire and then hitting a massive pothole.
Exactly. It most commonly occurs during sexual intercourse when the penis slips and forcefully strikes the perineum or pelvic bone. But it can also happen from rolling over aggressively in sleep, or a cultural practice called taekwondo, where it's forcefully bent downwards to cause rapid detumescence.
The presentation is unforgettable. The patient will report an audible snapping or popping sound, immediate loss of the erection, severe pain, and the classic eggplant deformity.
Right, the eggplant deformity. It's a massive hematoma confined by Buck's fascia. Interestingly, the penis typically deviates away from the side of the tunica rupture.
Because the hematoma forms on the injured side, pushing the shaft in the opposite direction.
Exactly. But while you are looking at the deformity, there is a major complication you must actively hunt for: urethral involvement.
The urethra sits right there on the ventral side, which happens to be the weakest point of the tunica albuginea. Urethral tears happen in about 20% of penile fractures.
So you have to look for blood at the urethral meatus, hematuria, or any difficulty voiding. This creates a significant diagnostic dilemma for test takers.
Let's talk about the listener's internal monologue here. You're in the emergency department, you see that classic eggplant deformity, and you know it's a fracture.
Right.
Your instinct is probably, I need an MRI to see exactly where the tear is before we cut. Why is that the wrong move?
Because that instinct will cost your patient their erectile function. In the vast majority of cases, you do not want imaging.
Just like with torsion.
Exactly. If the clinical picture is clear, imaging just delays the operating room, and delayed repair significantly increases the risk of permanent erectile dysfunction and painful curvature. The absolute priority is prompt surgical repair.
So how do they check for the urethral tear if they skip imaging?
Provocative testing. Current recommendations lean heavily toward intraoperative flexible cystoscopy right there in the OR.
Got it. And that surgical repair involves a circumcising subcoronal incision to deglove the penile shaft. The surgeon cleans out the hematoma and closes the tunica defect using absorbable sutures.
The material really matters here. You have to use absorbable sutures, otherwise the patient will develop painful nodules and scarring that ruin future sexual function.
And if the urethra was torn, it gets repaired over a Foley catheter that stays in place for at least 2 weeks to allow it to heal.
So a penile fracture is the acute loss of an erection. But what happens when the mechanism fails in the exact opposite direction? Let's transition to priapism.
This is the inability to lose an erection, and it creates a localized compartment syndrome that is just as dangerous as a fracture. Priapism is defined as an erection lasting longer than 4 hours without appropriate sexual stimulation.
But for the exam, you have to immediately divide this into 3 distinct categories based on their pathophysiology: ischemic, non-ischemic, and stuttering.
Let's start with ischemic priapism, because that's The most common and by far the most dangerous.
Yes. This is a low-flow state. The venous outflow is entirely blocked, trapping deoxygenated blood in the corpora cavernosa. This results in a highly painful, rigid erection.
But notably, the glans penis and the corpus spongiosum remain soft. Why? Because they have a completely separate venous drainage system.
Right. It's literally a compartment syndrome of the penis. The tissue is starving for oxygen while simultaneously drowning in its own acidic metabolic waste. If you don't decompress it within 24 to 48 hours, the smooth muscle undergoes irreversible necrosis.
Now, contrast that with non-ischemic priapism.
Non-ischemic priapism is a high-flow state. It's almost always caused by direct trauma to the perineum, like a straddle injury on a bicycle frame, that creates an unnatural fistula between the cavernosal artery and the corpora.
So arterial blood is just continuously dumping in, but because the venous drainage isn't blocked, the tissue isn't ischemic.
Exactly. It's constantly getting fresh oxygen. Therefore, it's typically painless, the erection isn't fully rigid, and it's managed conservatively with ice packs or arterial embolization. It is not a red alert emergency.
And then there's stuttering priapism, which refers to recurrent short-lived ischemic episodes that happen mostly at night. This is massively tied to sickle cell disease, where the sickled red blood cells mechanically sludge up the venous outflow.
Right.
But let's look at the etiology of acute ischemic priapism, because this threw me for a loop. I was looking at the etiology, and I fully expected PDE5 inhibitors like Viagra or Cialis to be at the top of the list.
Oh, yeah.
But they aren't. Antipsychotics and trazodone are. How does that make any sense?
It's a brilliant pharmacological trap for the exam. PDE5 inhibitors actually rarely cause priapism on their own. Normal detumescence relies on sympathetic tone, right? Alpha-adrenergic stimulation causes the smooth muscle to contract and squeeze the blood out.
Okay.
Well, alpha-adrenergic blockers, specifically antipsychotics and the antidepressant trazodone, disrupt that sympathetic tone. The smooth muscle can't contract, so the blood stays trapped. The exam loves to test if you know to review the patient's psychiatric medications when they present with priapism.
That is a detail you definitely need to highlight in your notes. So once you suspect ischemic priapism, you have to prove it with diagnostics.
Yes. You take a small needle and aspirate blood from the corpora cavernosa to run blood gases. If it's ischemic, the blood will look incredibly dark, almost black.
The PO2 will be severely hypoxic, less than 30. The PCO2 will be hypercapnic, greater than 60. And it will be highly acidic, with a pH less than 7.0.
If it's non-ischemic, the blood will be bright red with normal arterial gas values. But once you confirm it's ischemic, you must move immediately through the management ladder to achieve detumescence.
Step 1 is therapeutic aspiration and irrigation. You use a large 19 or 21 gauge needle, aspirate that dark acidic blood, and irrigate with normal saline. The goal is to flush out the sludge and clot debris.
And if flushing it doesn't work, you move to step 2. Intracavernosal injection of diluted phenylephrine. Since we know the problem is a lack of sympathetic tone, we basically manually provide it.
Phenylephrine is a pure alpha-1 agonist. It forces that cavernosal smooth muscle to contract, which squeezes the venous channels open and allows the trapped blood to finally drain.
Right. You inject 1 milliliter of a highly diluted solution, about 100 to 500 micrograms per mil, every 3 to 5 minutes.
But you must monitor their vital signs continuously while doing this, right?
Oh, absolutely. Phenylephrine enters the systemic circulation and can cause severe cardiovascular side effects, particularly systemic hypertension and reflex bradycardia. You have to be incredibly careful in older patients with cardiac histories.
If medical therapy fails, or if the erection has already lasted more than 15.5 hours, we're on to step 3. Surgical shunts. The surgeon creates a controlled fistula to let the blood drain from the highly pressurized corpora cavernosa into the soft corpus spongiosum.
The exam might mention names like the Winter shunt, the Al-Gorab shunt, or peniscrotal decompression. Tragically, if the priapism has lasted longer than 48 hours, the smooth muscle is already dead.
The tissue has fibrosed.
Exactly. Shunting won't save erectile function at that point. You move toward full corporal dilation and immediate placement of a penile prosthesis to prevent severe penile shortening.
Man, it's a brutal clinical escalation.
Yeah.
Which brings us to our final topic. What happens when these acute emergencies are missed? Or what if a patient has a congenital or endocrine issue from the very start?
We enter the chronic phase of reproductive health. Male factor infertility, which accounts for about 30% of all infertility cases.
To evaluate male infertility, the bedrock test is the semen analysis. But the MCCQE won't just ask you to interpret the results, they will test you on the strict physiological rules for how this sample must be collected.
The patient must observe a period of abstinence of at least 3 days, but no more than 7 days.
There's a very specific reason for that window. If they abstain for less than 3 days, the seminal vesicles haven't had time to replenish, so the volume and sperm count will be falsely low.
Right, and if they wait longer than 7 days, the motility and viability drop drastically because the sperm are essentially aging and dying while sitting in the epididymis.
The sample also has to be kept at body temperature and analyzed within 1 hour of collection to preserve motility. And if the patient chooses to use a condom to collect it, it absolutely cannot be a standard latex condom. The chemicals used in manufacturing latex are highly spermicidal.
Once the lab gets it, they compare it against the World Health Organization's normal reference limits, representing the 5th percentile of fertile men.
I like to compare the semen analysis to inspecting a factory's output.
Oh, that's a good way to look at it.
First, you check the total volume of product leaving the factory. Normal volume must be greater than 1.5 milliliters. Then you check the concentration of the product. You need more than 15 million sperm per milliliter.
Next, you check the logistics. How well are the delivery trucks moving? That's motility. Total motility must be greater than 40%.
And finally, quality control. Are the products built correctly? That's morphology. And strictly speaking, the WHO guidelines state you only need more than 4% of the sperm to have completely normal morphology.
4% sounds absurdly low for normal. But human reproduction is a notoriously inefficient process. You are producing millions of sperm, and the vast majority of them will have structural defects.
Now, if a patient gets one bad semen analysis back showing, say, a low sperm count of 5 million per milliliter, do we immediately diagnose them with male factor infertility and send them for IVF?
Not at all. Human semen composition is wildly variable based on stress, illness, and environmental factors. The standard of care is to repeat the analysis. But you have to wait 3 months.
Why 3 months?
Because a full cycle of spermatogenesis, from a primordial stem cell to a mature ejaculated sperm, takes roughly 74 days. If the patient had a fever or a viral infection 2 weeks ago, it might completely wreck today's sample.
You have to wait for the biological factory to complete a totally new production run. That 74-day cycle dictating a 3-month wait is a classic exam concept.
Right. Now, if that repeat test 3 months later still shows a sperm count less than 10 million per milliliter, you have to initiate an endocrine workup to figure out if the factory is missing its raw materials. You're looking at the hypothalamic pituitary gonadal axis.
You order an 8 to 10 a.m. total testosterone and a serum FSH. You check it in the morning, because that's when testosterone naturally peaks in the diurnal cycle.
If the total testosterone comes back borderline or low, under 300 nanograms per deciliter, you must confirm it with a second morning draw, this time adding free testosterone, luteinizing hormone, and prolactin.
Because elevated prolactin or suppressed LH could point you toward a pituitary adenoma. The semen analysis gives other clues too. If the lab finds more than 1 million leukocytes per milliliter, that's called pyospermia, and you need to hunt for an underlying infection.
Or, if you see a high number of sperm that are viable, meaning the lab confirms they are alive but they are completely immotile, you should suspect a structural defect in the flagellum itself, like primary ciliary dyskinesia.
It's all about connecting the specific numerical finding to the broader physiological system. The exam wants to see that you understand the mechanism behind the numbers, not just the numbers themselves.
So, to summarize our deep dive for you today, when it comes to the major urologic emergencies, remember that time is tissue.
Testicular torsion is an ischemic crisis requiring immediate surgical detorsion within 6 hours, and you do not delay for a Doppler ultrasound if the twist score is high.
Penile fractures represent a structural blowout with a 6 to 8 hour window requiring prompt closure of the tunica albuginea and a very high index of suspicion for hidden urethral tears.
For priapism, you must strictly differentiate between the painful, rigid, low-flow ischemic type that requires aspiration and alpha-agonist injections, and the painless, high-flow, non-ischemic type that is managed conservatively.
And finally, memorize those WHO thresholds for semen analysis and remember the 3-month rule for repeat testing due to the 74-day spermatogenesis cycle.
And as we wrap up, I want to leave you with a provocative thought to mull over. We've spent this entire time talking about the male reproductive system as a closed loop of plumbing, fascial engineering, and cellular factories. But consider how often these specific localized emergencies are actually windows into completely undiagnosed systemic diseases.
A patient presenting in the ER with stuttering priapism might be giving you the very first clinical sign of undiagnosed sickle cell disease.
Or consider the patient waking up with incredibly painful, non-priapic nocturnal erections. The sources point out that this is highly correlated with obstructive sleep apnea causing intermittent hypoxia during REM sleep.
The extreme vascular sensitivity of this system makes it incredibly vulnerable to subtle systemic changes.
So the next time you see a localized reproductive emergency, ask yourself, is this just a broken pipe? Or is the male reproductive system acting as the canary in the coal mine for a much larger systemic collapse?
It really shifts your entire perspective on patient care. Thank you for joining us on this deep dive. Trust your training, review those physiological pathways, and keep crushing your MCCQE prep.
Until next time, remember, whether it's the tunica albuginea holding back 1,500 millimeters of mercury or the delicate balance of alpha receptors controlling venous outflow, the engineering is flawless right up until the moment it isn't. Keep your eyes open for the structural failure. See you next time.